Hello, my name is Devraj Chowda. I'm a pediatric neurologist and epileptologist here in Las Vegas, Nevada. And today we are going to discuss about the patients with epilepsy and who have an insomnia. It's one of the common comorbidities with epilepsy. So first, we will start with the non-pharmacological approach. And primary thing in non-pharmacological approach includes cognitive behavioral therapy in insomnia and known as CBT-I, I for insomnia. And there are some key components in cognitive behavioral therapy. One of them is cognitive restructuring, where often patients with insomnia has this belief that they are not gonna able to fall asleep. That's how I am. That's how my sleep is. So that restructuring of the brain and giving more positive attitude about that, that primarily consists of this cognitive restructuring. Also, there is a stimulus control, and the other thing is a restriction of the sleep where your relationship with the bed is strictly for the sleep. It's like more like a bed with the benefits, no benefits. We are only using bed for the sleep. We are not doing like watching a television, not doing playing a video game, not on your phone. These are primarily consist of a CBTI. Now we will move forward with the pharmacological approach of the insomnia in a patients with epilepsy. So we, as a neurologist or an epileptologist, we are already using anti-seizure medications, which has the side effect of drowsiness. And they're very highly sedated drugs like clobazam or phenobarbital, and they have once a day dosing, so which you can technically use at the patient's bedtime. And if you use at bedtime, that help with the insomnia as well as avoid the daytime drowsiness. Even the medications like valproic acid and Topamax, who are twice the day dosing, but there is an extended release formulation available, which you can use it at the bedtime to help with the insomnia again and avoid the daytime drowsiness. Now you tried this, you tried non-pharmacological approach as well, it's not helping, then this is the time to go for more directly insomnia related medications. Now, pediatric and adult, that's how I'm going to divide today. The pediatric has a very limited medications approved by FDA for such conditions. And often the pediatric patients as autism and epilepsy are kind of coexisting and they have higher chance of insomnia and simply not addressing is not beneficial for the quality of life of the patients and parents. In such cases, we often start with the melatonin, and melatonin can be used as a circadian rhythm dose, which is very like a half a milligram or, and then the sedative dose is based on the weight, based on the patient's age. But this is a primarily approach for the patients with autism or patients with pediatric patients with an insomnia. Now, talking about the adult patients, they have much more options here. The adult patients with the insomnia, we divided into like primarily three main category. Often the patients have a mixed kind of insomnia where there is an initiation problem then of the sleep, then you have a maintenance of the sleep problem. And then you also on top of that, there's a lot of patients who have an anxiety which contributing to the insomnia. So when you have all these three combination, probably the best approach is to going with the doxepin. Doxepin is an antidepressant, and low dose doxepin has a very good effect on the patients with epilepsy who has an insomnia, and is an FDA approved drug for an insomnia. Now, patients who have a problem with initiation of the sleep, in such condition, you can use the Schedule Z drugs like zolpidem. The problem with the zolpidem is has a drug dependency, so you have to watch for. On the other hand, we have a problem with where there is a maintenance of the sleep. In such condition, you can use the medication like orexatin antagonist, and this medication's concern is that sometimes they can increase seizure when the patients with epilepsy, and that's what you need to watch for. Now, you tried the non-pharmacological approach, you tried the pharmacological approach. you're still not able to help the patient, and this is maybe the time that you want to refer the patient to specialist. Now, whom to refer is also very important. When the patient often has an epilepsy, who has very high level of anxiety, high level of stress, depression, that kind of patient may be benefited more by going to psychiatrist first, and to help the control the anxiety, may control the sleep. On other hand, patient with the sleep apnea, that kind of patients should go to the sleep specialist directly, in such condition. Or you tried all these medications and nothing work, and of course, your next step is to make a referral for the sleep specialist. Okay. In conclusion, the patients with epilepsy who has an insomnia, it's a comprehensive approach to help the patient using non-pharmacological and pharmacological approach. It is utmost important to address their sleep issues, because not having enough sleep not only affect the quality of life but also affect the seizure control. Also, please do not hesitate to refer to a specialist. The moral of the story: sleep tight, otherwise seizure will bite.